Welcome. Hello, everyone, and thank you for joining us for today's training, Suicide Safer Care for Primary Care Providers and Their Teams. I also want to thank our Primary Care Association partners in collaborating with us on today's training. My name is Rick Brown, and I am the Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training. If you have any technical issues during today's webinar, please reach out to me or my colleague Josh for help. For those of you who are new to ACU, we are a transdisciplinary membership network uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians in the healthcare workforce caring for America's medically underserved communities. We invite you to learn more about us and membership with ACU at clinicians.org. If you're interested in more resources on suicide prevention for patients and clinicians, we also encourage you to visit our Suicide Safer Care page, where you can find a variety of resources, including fact sheets, toolkits, archived webinars, and more. I'll ask Josh if he can put the link into the chat, and you can also scan the QR code. It's bit.ly/suicidesafer. Before we begin, I just want to go over a few quick housekeeping items. First, we will be recording this session, and we will send you the recording and slides within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll have a dedicated Q&A at the end of the session. As the training begins, Dr. Little will ask if you can please complete a pre-survey. Please be sure to complete this if you haven't yet. Also, please complete our post-survey and evaluation at the conclusion of our training. They're tremendously useful to help us continue to improve the quality of our trainings. Lastly, I'm honored to introduce today's speaker. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a national expert in suicide prevention, a faculty member in Zero Suicide, and previously served for over 2 decades as a senior VP for a large FQHC network in New York. We're excited to have her with us today. And with that, I will turn it over to Dr. Little to kick us off.
Great. Thank you, Rick. Really glad to be here. I'm really glad to get a chance to talk to you about Suicide Safer Care. We're going to spend the next hour or so talking about Suicide Safer Care and really want this to be a conversation. So feel free during the webinar to put a question in or comment in the chat. I do actually try to watch it as we go along, and then we'll have some time at the end for some questions or comments. We do have so many people on the line today, so a little hard to unmute people and do that, but feel free to put your questions in the chat. And so as we go forward, we're going to spend some time talking about Suicide Safer Care in the context of a primary care visit. And we're going to talk about Suicide Safer Care and what it looks like and some of the things that you could do. And for me, one of the signs of a training that is helpful for me is I leave and then I have some very concrete things that I can take away and do even that very day. So next slide. So as we go forward, really want to ask you again to fill out the pre-test. It really does help us and inform us. Go ahead. So I want to start with just actually sharing a little bit of a story from someone. Kevin Hines is his name. He's actually very well known in the suicide prevention field. Some of you may have heard of him or his story, but he actually talks a little bit about his experience and about being one of the few people who survived jumping off of the Golden Gate Bridge as a result of a suicide attempt. So we're going to take a moment or two and just listen to his story and then continue on.
At 19, I hit my breaking point. It was too much weight to bear, and I broke. And I made my way out to the Golden Gate Bridge on a bus, crying like a child, hoping anyone would stop me, wishing, praying someone would stop me. And nobody does. The bus gets to the Golden Gate Bridge. I walk out on the walkway. I pick a particular light rail. I lean over that light rail and I'm just profusely crying my tears to waters below. And the odd part is that bikers, joggers, tourists, runners, patrol officers searching for suicidal people, they went by me twice. A woman approached me from my left, and she smiled at me. I thought, oh, this lady's going to save my life. I don't have to do this. I don't have to die anymore. I literally left the fate of my life in this complete stranger's hands, which wasn't fair. She can't read my mind. She approached. I waited for the "Are you okay?" And instead she pulls out a digital camera and says, "Will you take my picture?" And I had to laugh at this accent, and I was like, terrible timing, you know? I took her picture 5 times. And she walked away. And I said to myself, absolutely no one cares. Which has to be the single greatest lie I've ever told myself. And then I jumped.
And so, as you can see, just sort of listening to this story, one of the things that people who are at risk for suicide or thinking about suicide are looking for is hope. People who have hope don't die by suicide. And we're going to talk about the ways that you can give someone hope during the course of a primary care visit and those interactions. And the thing about hope is anyone can give hope. It doesn't matter how long you've been at the health center, your licensure, your credentials, your background, none of those things. And so we're going to talk very specifically about what that looks like. But I thought it was interesting for you to hear just people are looking. He was looking for anyone to just say, "Are you okay? Can I help you?" to show some sort of concern. And so I think sharing his experience is important because one of the things we know is suicidal thoughts are not uncommon. It's not a question of if you're caring for people who are at risk for suicide, you absolutely are. Many people think about suicide and many people know how they would die by suicide. And so we're going to talk about how you care for them and what are some of the things that you can look for. Next slide. So as we start, it's really important to think about our language. You're going to hear me say died by suicide. We don't use the term committed suicide any longer. Think about like committing crimes as an example. We also don't use words like successful or unsuccessful attempt. I can't tell you how many people have been introduced to me. I'd like you to meet so-and-so. They had an unsuccessful attempt. What are we really saying? Like successful means you wouldn't be here anymore. Or you can't even die by suicide successfully, right? Also, words like manipulative or attention seeking, and oftentimes I see this in electronic health records and notes, and sometimes in big bold letters. Patient is manipulative, patient is attention seeking. And one of the things that I know is that if someone's talking to me about suicide, they're more likely to die by suicide. And so, really, just starting there. Also, I know all of you probably can think about a time in your life where you've had to say to someone like, that wasn't my intent, right? I tend to get in trouble a lot, so I have to say a lot of times, like, that wasn't my intent. And so I don't pretend to know someone else's intent. And it's more helpful for your team to talk about what someone said or did versus what you think their intent might be. And also to use words like caring for as opposed to dealing with. Go ahead. And so one of the things we know is that we're going to lose probably over 50,000 people this year to suicide. And those are just the folks that we know about. And so when we think about deaths from other causes, suicide absolutely ranks up there as one of the leading causes of deaths, particularly in some populations, which we'll talk about. And so it's really important to think about how much time am I devoting in my practice and to my patients talking about suicide, sort of compared to other ways that people are dying. Go ahead. So why are we focusing on primary care settings? A couple of reasons. One, many of the people who die by suicide saw their primary care provider in the month of death. In fact, we actually know that they saw them, people who were disconnected from care, like not in primary care, not in dental, not in behavioral health. They actually resurface in primary care the month of death. So primary care has a unique opportunity to identify and care for people at risk. We also know that there's an increase in patient portal usage, so much so that some organizations are saying, hey, like that's a flag. So really thinking about some of those pieces. and knowing that primary care has a very unique opportunity to identify people who may be at risk for suicide. I thought I would put this data in. I think it's interesting to know, often we're talking about firearms, to really see who is dying by suicide using a firearm. If you look at the 10 to 14-year-old population, you'll see that about 44% of the people in that age group who died by suicide or died by firearm were suicide. That number increases gradually as you go into the geriatric population. So when you think about those who are at the most risk for firearm, it's important to understand and know those age groups. Go ahead. Also to think about maternal suicide. So many of you might be caring for prenatal patients, for OB patients. We've seen a huge increase in maternal suicide, and 20% of the maternal deaths are attributed to suicide. And we're learning some things, but many of the suicides are occurring fairly soon. And so oftentimes when we see people at 6 weeks, as an example, that's about the time that we're losing many people to suicide. So it's really important to ask about suicide in your prenatal and postpartum patients. And oftentimes we don't think to ask about suicide because we think of childbirth or having a baby as sort of a time when someone might not be considering suicide. Go ahead.
With our first pregnancy, she did have a very serious case of postpartum depression. We were not prepared for it. We didn't think that it could happen to us. We weren't even very familiar with it. We were very, very much in the dark, both of us. Small signs of changes in her personality that if you didn't live with her, you wouldn't have noticed. And since we didn't have a lot of education in the field of postpartum depression, my first instinct was to chalk it up to just being a brand new mom and being nervous and it being a new experience for us. Recognize the person sitting in front of me. So we dropped my daughter off with her grandmother and got her to the hospital where they said, yeah, this is postpartum depression. It's probably one of the worst that you could see. It was a good plan. It made sense. We were going to get her on her original medication system. We were going to take any chances. She was going to go right back on it. But we just didn't anticipate how much faster it would return this time. And what happened over the span of weeks the first time happened over the span of 4 or 5 days, and we just were not prepared for it. We had 4 great years of her being the best mom she could be. She was a healthy, fully functioning adult, very warm, very happy, very outgoing. Just a very normal, very happy individual, which is what makes this all the more shocking that this happened to her. The change came so quickly and so rapidly, and we just weren't prepared.
So again, just giving you something to think about in terms of thinking about maternal suicide and really talking to your individuals who are potentially at risk for suicide. And so as we think about different populations, also thinking about youth suicide. So one of the things that we know is that the rates of suicide in the 10 to 14-year-olds are really going up. I never thought I would have to use youth and suicide in the sentence as much as I do now. And so one of the things we know is that it's the leading cause of death in that population. And when we think about what some of the numbers are, over 10% of the population is going to attempt suicide. And so when you think about how many that is in a particular high school classroom, how many classrooms in a hallway, how many hallways in a high school, you start to think about the numbers. And when we think about a fifth of the high school students are going to seriously consider suicide, those numbers are staggering. One of the largest numbers is largest causes is actually bullying. So you hear a lot about bullying as being a cause for suicide. Thinking about your geriatric patients, oftentimes geriatric patients don't even get referred for care because everybody's kind of like, well, of course they're sad, they're old, right? But actually they make up just under 20% of the suicides. And one of the biggest risk factors is losing a spouse or partner. So really understanding that in sort of your geriatric population is really going to be helpful. So at this point, Joint Commissions, CARFs, HRSAs, everyone is really starting to talk to health centers about suicide and really expecting that you've got some processes in place for suicide. And one of the things we like you to think about is to start to think about places that people are falling, through the holes, right? Or through the Swiss cheese, as they say. We like to think, let's wrap a warm fuzzy blanket around people who are at risk for suicide. So as an example, one of the biggest places that people fall through the cracks is the front desk. So think about if I'm thinking about suicide and I call and I cancel an appointment, or I try to make an appointment and there's no availability, and the front desk person doesn't know that I'm at risk for suicide, they can't do anything different. We've lost many people to suicide because there was no system to know that they were at risk for suicide or to know that they had canceled multiple appointments. And so thinking a lot of organizations, schools, primary care practices are doing something called Handle with Care patients. And so they're letting the front desk know, people know, so that they can do something different. So that's something to really think about in your system. And so really putting some of those systems in place. If you haven't gone to the Zero Suicide website, I really encourage you to do that. Lots of free information, training, all of those things that you'll find pretty helpful. Most organizations are doing a suicide care pathway versus a policy. And we'll sort of talk this through a little bit, but if you want any additional help or support in your organization, reach out to ACU and we can certainly work with you and give you some support. So when we talk about risk, we're going to talk about how do you assess risk? How do you know someone's at risk? There are some ways to do that. This is actually a new tool that many of you may not have seen. It's the new Child and Adolescent Columbia Scale, or CSSRS. We're going to talk about the CSSRS, but since we sort of talked about youth last, I wanted to let people know that this tool is actually out there and now available. So this project is part of a larger project where we've gone around and I think we've trained probably about 3,700 providers and their teams. And there's a couple of things that we've heard. So the first thing we hear is like, I just don't know what to do. And many people have not gotten training, right? I know I have a master's in social work, a doctorate in psychology. Nobody ever really gave me any formal training on how to care for someone at risk for suicide, which is about what half of our behavioral health providers in FQHCs are saying, like, we never actually got any training on how to care for someone at risk for suicide. So a lot of times what we hear is, I don't actually know what to do. So you heard me mention in the beginning that hope really saves lives and giving someone hope. So what we like to do is to think about, what do we want to say to someone who maybe just told us for the first time that they're thinking about suicide. So I know I have times in my life where I have told someone something that I wasn't really sure I should tell anyone. And the first couple of seconds, literally the first couple of seconds after you tell someone, you can have a, oh shoot moment, I shouldn't have said anything, or, oh, this was a good idea, I'm really glad I said something. And you know that very quickly. And so if you think about when someone tells you they're thinking about suicide, maybe for the very first time, you want to be able to let them know right away that it was a good decision for them to talk to you or to talk to someone. So we came up with something that we call storage statements. And storage statements are things that we think about ahead of time that we have that we can sort of pull out and use when we need them. And so because sometimes when people, tell you that they're thinking about suicide, it's not expected, right? It's like, you weren't expecting it. I had someone reach out to me recently, and they talked to me and they said, listen, I remember you saying your storage statements, and boy, was I glad that I had done that, because I was driving my daughter and her friends to practice and someone made a suicidal statement. And she said, I was really glad. So you usually are not expecting. And so when we think about storage statements, we think about 2 or 3 sentences that we can say to someone who just told us that they're thinking about suicide. The first thing we want to let them know is, I heard you. Thank you for telling me you're thinking about suicide, not about hurting yourself, not about suicide, right? Thank you for telling me you're thinking about suicide. We want to let them know they're important. Your life is very important to me. Your life is important to us here at the center. I have hope for you. It took a lot of strength for you to tell me you were thinking about suicide. So those are really good examples of like 2 or 3 sentences that you can use when someone tells you they're thinking about suicide. And so your homework is to think tonight, when you're brushing your teeth, you're sitting at the dinner table, at a staff meeting, at the break room, to think about 2 or 3 sentences that you could say to someone who just told you they're thinking about suicide. And I have so many people come back to me and say, Virna, I did not do my homework, but boy, was I glad I remembered your storage statement. So really think about it ahead of time. And the other thing we've heard is like, I just don't have time, right? I don't have time to address or ask for, around suicide. And so I would say, having worked in primary care practices for many, many years, one of the things I know is that it would be a beautiful day in primary care if somebody came in for just one thing, and the one thing they came in for was actually the most important, right? We switch gears all day long. We do it better than anyone else. And so I often like to tell a little bit of a story, which is a true story. My husband was hit by lightning, lost a good chunk of his hearing in one ear, and we were going to the primary care provider. And we went in, and lovely medical assistant took his height and his weight and his blood pressure and kind of left the room. And I was like, okay. And so a couple minutes later, the primary care provider came in and she said, I'm going to recheck your blood pressure. And she checked the blood pressure and she said, listen, your blood pressure is out of, off the charts. And I'm really concerned about you. And I'm not sure what we're going to do today. I'm not sure you're going to be able to go home. She asked him some questions, got a little bit of information, said, listen, I'm going to go finish up with my other patients, and then I'm going to come back and we're going to figure out what to do. And she came back. We never talked about his hearing loss again during that primary care visit because it was no longer front and center. And so people always ask me, well, what happened? Well, an ambulance ride and a stent later is what happened. But the reality is that it wasn't front and center anymore what we had gone there for. And so the same is with suicide. When someone says yes to suicide, we stop, we get some information, and we come up with an appropriate plan of care. And we're going to talk about how to do that during the course of a primary care visit and what that looks like. Because what we don't want you to do is panic. We want you to listen, right? We want you to use the word suicide and give some hope. So in other words, use your storage statements, right? That's going to be incredibly helpful for you. Now you have these storage statements. So a couple of things that just to sort of give you some additional information, things to think about. So you've heard me say a couple times, say suicide directly. Ask patients directly what you want to know. I remember, when I started, I worked in family violence, and providers would always say, well, I ask people if they're okay. And I was, I would tell people, well, that's not necessarily the same question, right? Because if you ask me right now, am I okay? I would say, actually, not really. I'm in a hot, stuffy place doing a presentation. My throat's a little sore. I've had kind of a chaotic day, right? So no, not actually okay. But what you really want to know is, does anyone hit or hurt you at home? So the same thing with suicide. We want to ask what we want to know. Not are you thinking about hurting yourself? Because particularly with adolescents, that could be cutting, right? And so many of my patients who talk to me about some of the same struggles that you're having, think about suicide. I'm wondering if you are thinking about suicide. We also spend a lot of time screening for depression, and we're going to talk about that. But also remember that many people who die by suicide don't have a mental illness at the time of death. There was actually a big article that came out this week that talked about adolescents and how like half of them had no mental health history. And so this was very different from how I was trained, right? It's so many people who die by suicide don't have depression, and many people with depression, major depression, are not suicidal. Anxiety is a huge risk factor for suicide, and also social determinants, the housing, the finances, all of those things, right? They are huge risk factors for suicide. Substance and alcohol certainly play a role, and also transitions. And it's not just transitioning out of a hospital, it's transitioning foster care, incarceration, substance abuse treatment, physical rehab, now summertime, or going back to school. Think about if I'm an adolescent and I get really bullied at school and summer is ending, right? So those transitions are a huge risk factor for suicide, but really important to think about. We had a provider, and she talked about a patient, and she stood up at one of these presentations and she said, listen, I had this guy and we were really worried about him. And I saw him and my team saw him and I called him and my team called him, and he died by suicide recently. And we never asked him about suicide, but now that I think about it, he was having some health problems. He couldn't work. They started to have financial problems. They were at risk of losing the home. His marriage was, struggling as a result. He started to drink a little bit more than he should. And she's like, he was absolutely at risk for suicide, but we never asked. And so really rethinking those social determinants and who might actually be at risk for suicide. I saw a provider the other day and I was telling them about this training, and they said, well, we don't see patients with, severe mental illness. We refer them all out. And I said, well, I'm sure that you actually do see people who have behavioral health conditions, but I'm also need you to know that many people who die don't have a behavioral health condition or diagnosis, right? So really important to understand some of these pieces. And the other piece is to really understand that it's important to know your population of people at risk for suicide. Oftentimes I ask practices, so how many diabetics do you have? And they tell me, I have this registry and here's the diabetics, and they tell me all about the work they're doing. And I say, well, tell me how many people you have at risk for suicide. And they can't. And so one of the most important things you can do is start to put suicide on the problem list. There are ICD-10 codes out there that you can use. It's really important to use them for a couple of reasons. One is so you know your population, but two, it's a quality issue. If I'm covering for you, I'm going to ask different questions or make different decisions if I see someone is at risk for suicide. The other thing is we spend a lot of time thinking about the people that we just identify and not about what happens. So I'm a diabetic. When I go in to see my primary care provider, there's things that happen because I'm a diabetic. So what things happen if I'm at risk for suicide? At the very least, if it's on the problem list, we can ask if someone is safe. We can at least address the suicide. I often like to tell a story of an adolescent. He went into school-based health center, needed football forms filled out, right? And so he went in, said yes to a suicide question, lots of commotion, right? He got referred out. He came back 3 weeks later, same forms, saw a different provider. Suicide wasn't on the problem list. Came in, got his forms filled out, and left. Nobody asked him if he was safe. Nobody asked him about suicide. Nobody asked him if he was in care. And this happens all the time because we're not putting suicide on the problem list. And every once in a while, somebody, usually behavioral health providers, but somebody will say to me, I don't think my patients, I don't know about putting suicide on the problem list. And I say, well, I'm not sure why we're talking about not putting a life-threatening condition on the problem list. Particularly one that we're identifying and caring for. But what I let people know is, your life is really important to me. And I just want to let you know that I'm glad you talked to me about your suicidal thoughts today. And I put a note in your chart because I want to make sure that every time I talk to you, or my team talks to you, or I see you, or my team sees you, we make sure you're safe. And so that historically has been my experience, that people actually really appreciate having someone care for them. So we did touch a little bit on depression screening. So on the right, you'll see the PHQA, which is the depression screening for adolescents, right? And you'll notice here on the bottom, and we'll talk about what those questions are, they're asking very directly about suicide. If you were going to talk to folks in NIMH, they would say, really ask 10 and up. Ask everybody when you see them directly about suicide. So many practices are doing that. We also know about the PHQ-9 that people who answer yes to question 9, thoughts that you would be better off dead or hurting yourself in some way, right? That people who answer yes to that are in fact more likely to die by suicide. And so we know this. And so it is really important to ask them, right? However, we also know that in many practices, this is the only time people are asked about suicide. So I really encourage you to think about other ways that you could ask about suicide. But certainly it's a good place to start. So what I like to do is I actually talk to people about what they're telling me. So I see that you're having some difficulty falling asleep and staying asleep. And that's a problem for you more than half of the days. And I see that you're having some difficulty concentrating, like on TV and the newspaper, and that's a problem for you nearly every day. So it seems like sleep is really a problem for you each day, and we really want to make sure that we try to figure something out with you. I also see that you have thoughts that you would be better off dead or hurting yourself, and that's a problem for you several days. So thank you so much for telling me you're thinking about suicide. Your life is really important to me. What I'd like to do is just start with your thoughts of suicide and ask you some additional questions so that you're moving from the PHQ, taking all the information someone gave you, and then saying, okay, listen, I'm going to start here because actually the most important piece is your thoughts of suicide. So there are 2 evidence-based tools for risk. This is the ASQ. If you literally Google NIMH ASQ, you'll find it. I actually like it better for children and adolescents. It has a really nice script for nursing staff, really nice script for parents or guardians. And I also like question 5, are you thinking about killing yourself right now? If the answer to that is no, that's crystal clear, right? And then we need to be able to get some information and put a little bit of a plan in place. The ASQ is not in many of the electronic health records, but I think it's really worth knowing about it. A lot of times organizations will use the ASQ to initially sort of ask about suicide. So really thought I would share it with you. It's a nice tool. So a couple of things to think about. One of the jobs that we want to do and make sure, just like you do for any chronic condition, is you want to make sure people get the appropriate level of care. And so I worked in an emergency room for 17 years. I can tell you no magic happens in the emergency room around suicide. In fact, one of the things we know is that many people who go to the emergency room don't stay in the emergency room. And we know that sending someone to the emergency room for suicide who doesn't need to be there can actually be at more risk. And so what we really want to do is we want to figure out who actually needs to be in the emergency room and make sure that they get there just like we do with any other condition. It's kind of like asthma, right? We don't send everybody with asthma to the emergency room. And what would happen, right? People would say, well, you know, I don't want to go to the emergency room. I don't need to go to the emergency room. And so I'm just not going to go in, right? And then we're going to have people with suicide or asthma staying home and not coming in, or say they're just going to send me to the emergency room, so I may just go there. And we don't want that either, right? We want to make sure people are getting the appropriate level of care. And in order to do that, we need to assess risk and have some understanding of risk. And so you can have the conversations. We have the tools for you to be able to do that in the course of a primary care setting. So this is the Columbia scale, or the CSSRS, which is in virtually every electronic health record. And so a couple of things to really understand around risk. So, and we're going to talk about them sort of in context of our yellow, orange, and red. So a lot of people can think about suicide. Lots of people think about suicide. A lot of people know how they would die by suicide. It's the intent. Have you had these thoughts and do you intend to act on them, right? Do you intend to carry out the plan? The intent is what makes the difference. I often talk about a patient that I had, and he was in upstate New York, and he talked to me about, there was a walkway over the Hudson River, and he thought about suicide. And I asked him, and he said, well, I would jump off the Mid-Hudson walkway. And he proceeded to tell me exactly where he would jump and why. So we used to do something terrible. I used to write, patient has suicidal ideation and a plan, and off they would go to the emergency room. That was terrible care, but that was all I knew at the time. Now we really understand that it has to do with intent. And I said to him, do you intend to jump off the Mid-Hudson walkway today? And he said, no. In fact, I'm late for work, right? I have a girlfriend, I have things, right? So he didn't have intent. And that's really the key. So people who answer yes to questions 4, 5, and 6 and have intent are people that likely need another set of eyes. And we're going to talk about what to do with many of the patients who really are in the yellow or orange areas here on the Columbia scale who don't have the intent. And that becomes the key. And balancing that intent with what we call protective factors or reasons for living. What are some of the reasons you wouldn't die by suicide today? And people have thought about how not to die. And I ask people very directly, what are the reasons? And a lot of times people will say, well, my family, right? My kids. And I say, yes, your children absolutely need their mom. My pet, sounds like your pet is really important to you. They really depend on you, right? Adolescents, you're going to hear my friends, right? My parents. A lot of healthcare workers, people say their job, their patients, my religion. And so think of it like a seesaw or a teeter-totter. If I have intent and I don't have reasons for living, then I'm more at risk. If I have reasons for living and I don't have intent, then that's someone who's safer. And so you're weighing those back and forth. So I had an adolescent recently, and, he said, yeah, I'm absolutely going to take my life. I intend to carry out my plan. And I said, well, what are some of the reasons that you wouldn't, use your parents' gun to die? And he said, there is no reason. My family has a lot of kids. They're not even going to miss me. Like, I don't have friends at school. Like, there's no reason, right? So that was a kid that I was pretty worried about because he had intent and he didn't have any reasons for living, even when I, tried to really engage him around that. And so really weighing out the risk and the protective factors. And then doing a little bit of safety planning. We used to do something called contracting for safety. We don't do that anymore, right? We know that it's dangerous. We do safety planning. And safety planning can happen differently based on your yellow, orange, or red patients. So the minimum that we want to do is I actually have people take out their phone and put in the lifeline, whether they want to put it under lifeline or suicide or whatever they decide, right? Then it's there. Because one of the things we know is that the lifeline has actually been shown to be evidence-based, reduce suicidal thoughts and behavior, and actually be more effective than behavioral health treatment in cases. It's available 24 hours a day. And it is actually, most calls are resolved on that call and don't need a follow-up. And so I will often say, why don't you give them a call? I'm going to go see another patient and I'll be back, so that they actually know what happens when they call. Now you've given them an evidence-based intervention available to them 24 hours a day. They know what happens, right? It's now a resource that feels very accessible for them. The second thing that I do for them is I give them the Now Matters Now website. This is actually evidence-based. It's been shown to reduce suicidal thoughts and behaviors. I go on, have them save it on their phone. I used to have a tablet that they could go on, say, listen, why don't you play with it a little bit? I'll come back, right? So now you've given them 2 evidence-based interventions available 24 hours a day. This is really good, particularly for your yellow patients. One of the things that we want to do is give that information out, right? Also, sometimes for parents or guardians, we actually give the Suicide is Different website. And one of the things that it does is give some support, but they can also get a follow-up phone call now. And so that's also really helpful for people to be able to give. So the thing about risk is that we all know risk can change, right? So risk is now, or safety plans and suicide risk are starting to be equated to like fire safety. So we have over 100 people on this webinar, and I guarantee you, if we were all in a room together and I said, listen, if you caught on physical fire, do you know what to do? And every single one of you likely would raise your hand and you would tell me stop, drop, and roll. Like me, you probably don't remember when you learned it, but you know what to do if you catch on physical fire, even though the likelihood that you're going to catch on physical fire is pretty low. So we don't know what to do if we catch on emotional fire, even though these days the likelihood of catching on emotional fire is higher. And so I let people know, here's a plan for when or if you catch on emotional fire. And this could get printed off the Now Matters Now website. So it's really helpful to give people. So you could give it out to your yellow and orange patients or even your red patients, right? They now have this emotional fire safety plan. And I give them the same analogy. Now you know what to do if you catch on emotional fire. You already know what to do if you catch on physical fire, right? Even though the likelihood is low. So oftentimes people are like, I don't need that. Well, you know what to do if you catch on physical fire. Here you go. So it gives you some language to be able to have some of the discussions is really helpful for people. This is actually a longer version of a safety plan. It's called the Stanley and Brown. It's the one that is in most electronic health records, and you can certainly fill them out for your patients. Safety planning is evidence-based. There's a couple of things that I often see in safety planning that aren't there and are really important. The first is if you're going to help someone pick an activity, you have to pick something that's available right away. So if I'm going to go outside and swing on my swing set in the backyard, that's not something I can do at school. So I need something that is going to be available to me right away. And I can have a couple of things, maybe one for home and one for school, right? And then can that activity take place 365 days a year, 24 hours a day? So it might not be safe for me to walk in some neighborhoods at 2 o'clock in the morning or to swing on a swing set when the weather is really bad in January at 2 o'clock in the morning. And so you really want to make sure that that activity falls into that bucket. And also people to call. So if I'm going to put down that I'm going to call, Jennifer, and Jennifer's going to be on my safety plan, then we're going to call Jennifer and we're going to talk to Jennifer about being on my safety plan. And that's going to be incredibly helpful because maybe Jennifer says, oh, great. Or maybe Jennifer says, listen, I would love to, but I work for this amazing organization, ACU, all day, and I'm really busy and I can't pick up my phone. So then we want to say, okay, we're going to call the lifeline if Jennifer doesn't pick up, right? And so that's actually going to be really helpful for people to make sure that it's covered. And then I always ask people, how can we keep you safe today? Like if we were going to keep you from dying by suicide today, what would we have done? That's often really helpful because people have thought about how to stay safe. People have thought about these things. So when we think about lethal means restriction, it's really important to know the way that people would die. Oftentimes, if I'm thinking of dying by suicide and using a gun, I'm not likely to change that, right? So it's important for us to know and note in the chart how someone's thinking about dying by suicide. And then we want to talk to them. It's temporary. This doesn't mean you won't be able to go hunting in the fall. This doesn't mean you'll never be able to drive again. This doesn't mean you won't be able to, hold on to your medication. This is what I do for all of my patients who talk to me about suicide so that I can make sure that they don't die by suicide. And you want to make sure that you note it in the chart so that I know if I'm covering for you, what that looks like. And what we know about lethal means is if we can delay the time. So in other words, those individual pill packs where I have to take time to open every one of them, then that actually saves lives. If I have a key for my gun lock and it's frozen and I have to melt it, right? The time that it takes for me to access the lethal mean is really helpful and actually saves lives. And the other thing we really want to make sure is that we're asking people, where would you get the means? So oftentimes we think about, well, it's the medication we're giving them. But I like to ask, so you've talked to me about dying by suicide or your thoughts of suicide and using medications. Where would you get the medications? Oh, I pass CVS every day on the way home. Or when my grandma died, my aunt saved bags of medications, right? So that you're really making sure. I've had so many adolescents who, would say to me, my parents went to a lot of trouble to make sure that there were no guns in the home. But I go visit my neighbor next door and they have guns. They have lots of guns. His dad has lots of guns. Or they forgot about the gun on the mantle and that's loaded. So I'm really clear to ask, where would you get the gun? Or where would you get the means? And also, it may mean that, you have several places or several steps that you need to go to. And sometimes people will ask me, particularly in places like New York City or well, there's a pharmacy on every corner, or, there's buildings everywhere, or subway stations, trains everywhere. Then I will say to people, if we were going to keep you from dying by suicide, from jumping off a building, what would need to happen? Well, I would need to make sure I wasn't home alone. I would need to make sure that the lock is actually on for the door going out to the fire escape. Maybe at times I would need to make sure, and they've thought about reasons. So sometimes you really have to problem solve. And I do ask it retro, because sometimes people what would we need to do is harder to ask them, what would we have done? So oftentimes thinking about what that would be, right? So I had someone and she was going to drive off of a ledge, and she came up with, well, I will carpool a couple of days because I would never drive off the ledge with other people in the car. I'm going to pull over on the other days and call my mom and have her on speakerphone. And I'm going to put a picture of my kids on the dashboard. She came up with all of those things to be able to keep her safe. I've also learned to have some different discussions around guns. People have some very strong thoughts about guns. And so I say, if we were going to keep your gun safe, so we're not taking your gun, if we were going to keep your gun safe so that it wasn't used for a purpose for which it wasn't intended, or so that it won't be used for you to die by suicide, what would we need to do? So really kind of reframing that discussion a little bit and really engaging people. The other piece to talk about is what we call caring contacts, which are messages that we send to people. They actually came out of Australia, where people would get discharged from the hospital and go out into the outback, and they knew they weren't going to see them. So they sent them a note. Hey, hope this note finds you well. And they actually reduced suicides, because just knowing that someone out there cared reduced suicides and gave people hope. So a lot of practices will send caring contacts when they see someone for the first time. Send a little note. Hey, it was really good to see you today. Looking forward to seeing you next week, right? Really had enjoyed having a chance to meet you. So caring contacts is something that you can think about incorporating. Here's some examples of them. There's lots of examples on the Now Matters Now website or online. And there's actually even some places that do it. If you're interested, where they actually will help you and do it for you. Resources that are out there. There are some resources out there. There's mood tools and some other things that you can use to really support. And so what we'd like to do is just take a moment now, have you fill out the post survey. We'll post that in the chat for you. and then give a little bit of time to answer some questions in the chat. So encourage you to put some questions in the chat, and I'll try to go back and answer some of them that came up while we're here. So someone asked me about liability. So it doesn't decrease your liability to send someone to the emergency room, especially now that we know that somebody could be more at risk. The best thing you can do to reduce your liability, if you're concerned about it, is to follow evidence-based practices and have a pathway. So the resources are free. PUPS is not. People ask me to put that in there, and yeah, they do actually work with you. I'm not sure what they're doing currently, but they do a nice job of it. And I've been meaning to update that slide to be able to put that information, so I'll reach out to them. But PUPS is the one that isn't actually free. The others are. Good question. Question in here to me about ages again. So for the 10 and up, really to be screening pretty routinely, and 6 to 9 if it comes up. And yes, we are actually losing 6 to 9-year-olds to suicide, unfortunately. But 10 and up, you should be asking pretty routinely. Whether you use the ASQ or whether you use the child and adolescent version of the Columbia scale. Do you put the questions in your portal? Absolutely. So a lot of organizations that came up today are taking question 9 off of their portal. I would absolutely not do that. There's language that you can put like, hey, here's the lifeline number to call. Someone may not get this right away. But yeah, you can absolutely ask the questions and should ask the questions. Great questions. So contracting for safety isn't done anymore because we really think about we know that it actually doesn't work and has actually shown to be dangerous, but think about your diabetic patient and we have them sign a contract that says, I am not gonna eat anything that won't be healthy for my diabetes, right? Like it's actually kind of a meaningless document. You have to sort of engage someone in the process, right? And that contracting for safety was really all about us wanting to make sure we didn't have liability or thinking that we didn't have liability. And so I think that, you know, we've moved away from that. And safety planning is such, you know, a collaborative process. It's really helpful. And it's a lot of fun to be able to do with patients so that, you know, you can really problem solve with them. We often get patients in our EDs because providers send them. Very pleased. Yes. Would love to be available at any behavioral health steering committees or any other places where you think me or this information could be helpful. I worked in an emergency room for 17 years, doing like suicide, you know, people getting sent from the community. And I would say I sent most patients did not need to be there. And it was really frustrating for me because I was using tools like the Columbia scale and things to ask questions that could have happened with someone who actually knew them better. And so it was pretty frustrating. And I think that it's really important to make sure the right people get to the right places. And I would feel terrible. Sometimes I'm discharging someone at 2 o'clock in the morning. You know, they don't necessarily have the greatest plan in place. It would have been way better to be able to get them connected earlier in the day. And so I think that's, you know, really a helpful piece. Yeah, the Stanley and Brown in our EMR. Yeah, absolutely. It's an evidence-based tool. I would say that I fail about 85% of the safety plans I review for some of the reasons that I just talked about. Activities not being right away, 365, 24/7, not calling the people who are listed as resources. But yeah, absolutely. Do your Stanley and Browns, do them comprehensively, make sure the activities are personal, right? That it's, what playlist, why. Yeah, awesome. Great questions. Well, thank you, everyone. So I'll just take this last question. Putting suicide codes in the problem list, do you find that some patients are upset by having the sensitive information? No. I would actually say that's not been my experience at all. And not only that, my husband has chronic kidney disease. And that actually has caused us, some problems in terms of insurance. But I would never even remotely say that it shouldn't be on his problem list, right? It's a acute condition that he's getting care for. So we wouldn't do this for any other condition. It is a life-threatening condition that we're identifying and treating someone for. And it's really important to have the conversation about putting it there. I would also say that, when you tell people that you're putting it there because you care about them and you want to make sure you're asking about whether or not they're safe every time someone talks to them, then that's the key. And I have worked in a system, and I had several thousand patients on a suicide care pathway, and they could see information on their chart. It was on the problem list, and I never got anybody who said, why is that on my problem list? I don't want it to be there. Overwhelmingly, it was STDs, morbid obesity, HIV, some other things. It was never suicide. And I wouldn't respect that if they asked me not to put it there, because it would be like asking me not to put diabetes there. If I said to my primary care provider, listen, I think this diabetes thing's going to jam me up a little bit, right? I don't actually want, we're self-employed. I don't think I want my employer to know I'm diabetes. I'm actually going to be getting some life insurance, right? No, I'd prefer you didn't put it on my problem list. He would be like, no, I can't do that, right? Kind of the same thing. And I don't mean to be flippant about it, but actually we need to start thinking about caring for individuals. We're treating the whole person. We need to put everything that's important to their care on their problem list. Thank you. Rick, I'm going to turn it back over to you to close us out.
Wanted to finish up by letting everyone know that we will be sending out the recording of this webinar within a week of hosting it. And also, we also encourage you to find more resources at clinicians.org on suicide safer care as well. We'll be hosting our next session in 2 weeks, and we'll also send a reminder email. We hope to see you there. Thanks so much for joining us today.
Thank you. Have a wonderful day.